Okay, so everyone, welcome back and welcome to our second session of the day. Thank you very much again to the speakers of the first session for those wonderful and interesting lectures, and also thank you everybody for the great discussion we already had. For those who don't know me, let me introduce myself real quick. My name is Coccyx. I am of Greek heritage, but I was born and raised in Cologne in Germany, where I studied medicine before I moved to Munich, where I specialized in neurosurgery. And then I went on to specialize in interventional pain therapies and specialized pain therapy. And I've been working with Dr. Toma at the Algesiologicum for 2.5 years now, where we do mainly neuromodulation techniques. So for this session, our first speaker that I'm going to introduce to you now is going to be Sitske Lohov-Venema from the Netherlands. She is a physiotherapist who has specialized in pelvic physiotherapy and owns her own private practice in Wildervank, which is outside of Groningen. Groningen is a beautiful city in the northern part of the Netherlands, where she also studied physiotherapy, and then she specialized in pelvic physiotherapy in Rotterdam, and later mastered pelvic physiotherapy in Amersfoort. And she's also the creator of the NIMOC technique, which is short for non-invasive mobilization of the coccyx, a technique that is used to treat the coccyx for repositioning of an abnormal position without invasiveness, and which is very mild technique that is in general not painful to the patient. So this is going to be very interesting to hear about that. She's going to talk about position of the coccyx, its muscles, ligaments, and fascia. So with no further ado, I would like to hand the screen to her now for the first lecture.
Hello, can everybody see me, and is my voice good?
Yes, perfect.
Thank you, Mr. Coccyx, to introduce me. Thank you for this congress, and thank you for all the people who tell some interesting things. I will tell something about the position of the coccyx, its ligaments, muscles, and fascia. I have to try something. Do you see me now? Yes, I think. It's my third. My screen doesn't go to the other one. Yes, there I am. First, I will tell you something about the flow chart. After the Congress in Dordrecht, we make a flow chart for the pelvic physical therapist, when to treat and when to refer to other specialists. And the other thing I want to tell you is which tissue can be responsible for coccyx pain, which pelvic physiotherapists can treat. We all know that coccyx pain has much impact, and there are different causes and there are different treatments. This is the new flow chart. I will start with the first little thing. It's first when patients come in our practice, the first thing that's very important is the history of what has happened in their lifetime, special life events, accidents. People forgot sometimes they had a car accident, and then they're coming back the second time, and then their husband or their wife had said, "Oh, did you know you were falling from the stairs, or you had a car accident?" So it's first know and interesting and important to know if the history is a trauma or idiopathic. And before we start with the physical therapist, we had to know what's happened. And Mr. Skalski did his research with the MRI. What could be happened to the coccyx? What they can see by the MRI. And by us, it's important when there is a trauma that you have to exclude fractures because then it's not, at that moment, it's not allowed to do the mobilization from the NEMOC mobilization. That's a red flag, and then you had to wait, the fracture is gone and it's recovered. Or idiopathic, when you had to exclude neoplasm infection, crystal deposition, cystic fibro deposition, and sacronoduly. So it's important to know there are no red flags, and when they are not there, then is the first thing I think what's important for a pelvic physical therapist and for everyone to look to the location of the coccyx, because when a shoulder is subluxated, it's first important to re-put the shoulder, and so it's the same by a coccyx. So the first thing what can get problems and pain is a dislocation. So you can feel if the coccyx is in line outside, over the underwear or under the underwear, you can feel if the coccyx is in line. When the coccyx isn't in line, then there is you can do the NEMOC mobilization, or you do a rectal mobilization, just as Mr. Mouse told. It was also long ago they did it. And when the coccyx, and it's important to look to the rectal assessment of the hypotonicity of the pelvic floor. And first the coccyx mobilization, and then you look to the capsular ligament and periost. And in the next presentation later, I will tell more about the treatments, but the first thing, what's important is relaxation. And I think relaxation is the most important. Oh no, sorry, I was too quickly. First, it's important to look if there's a problem with the psychological problems, because there are much patients who have had an abused in their life when they are young, and then it's important not quickly to go to the coccyx, but first do a psychology program, because when you go too quickly to the pelvic floor, to the NEMOC you do the NEMOC mobilization, then there will be there's a possibility there will be a bigger trauma, a bigger problem. So first you had to look if it's possible to do a mobilization. And then for the physiotherapist, what you are allowed to do, what you can do is look at the relaxation. And I think the most important thing you can do is relaxation, because when you don't do, a patient doesn't relax, you can do everything biotherapy, but when there's no relaxation, the muscles are strained, the coccyx, and the complaints are still there. And avoiding pain, cushion advice, posture advice, you can, as a physiotherapist, treat the trigger points, the stretch techniques, tense, functional training, training in chains, and always from local to total. Or if it's so painful, then sometimes it's better to start total and then go further to local. When the physiotherapist has insufficient effect, then it's important to work together with osteopaths or a manual therapist or a fascia therapist or a chiropractor, or you work together and you treat together. And I think one and one is 3 or 4. I think it's good to work together, and for the patient it's better because you work on different tissues. And when there's the problem is not over, or the patient can't dealing at a good way with the chronic pain, it's important to do a special program to dealing with chronic pain. And when that's not enough and it's not still insufficient effect, then it's good to go to a pain outdoor, to an anesthesiologist, and you all are better of that than me. What injection on, and I think that's a good opinion, and you can help patients good And when that's not enough and not enough effect, then it's good to go to the surgeon. So I think, and we all know that there are good results. And I think first it's important to work to the other things to treat with the physiotherapist or relaxation. And at the later stadium, I think it's a good opinion to do a surgeon. When we look to the lateral deviation, there's a little, known is in the literature and in the research. Female by a research of Lee in 2016, that you can feel that the finger, when it's outlined, 62% of the female are outlined, 52% of the male are outlined. And Lee thought there's a lateral deviation of the coccyx and it may cause the coccydynia by compressing the coccygeal nerves. But I also think that when the position it's not in line, that the joint also give the problems and the capsulaire also give the pain. For the Nymock mobilization, the Nymock mobilization is a mild mobilization you can do while patients are sitting. They sitting relaxed, and it's almost all time not painful. And it's a mild mobilization. And in our center, we treat more than 1,400 patients with coccyx pain. And I think, the patients who come here, were mostly before at other places in Holland or in Germany or from Spain or France. Sometimes they come, and they have much pain. And I've educated 350 pelvic physiotherapists in the Netherlands, and 245 from those pelvic physiotherapists are skilled, and they are standing on the website, so patients can find in their neighborhood someone who can also treat with the Nymock mobilization. And I've also educated in Belgium, Germany, and England. And last year we started also for physiotherapists with no pelvic education background to do the course. But it's very important they know to ask in anamnesis in the history if there are also problems with the pelvic floor. And it's important that they know that they had to refer to pelvic physiotherapists when there are problems in the pelvic floor. The coccyx is not always in line, and I think that's give a reaction in the total body, not only in the coccyx get the problem, but also joints and capsular and muscular and ligaments. I don't know if you can see it. Yes, you can see. It's the same as you see there. The wooden that are the bones, and the other things are the muscles and the fascia. When you change here something, you can see that the whole body changed. So what's known in the literature is that Perkins in 2003 saw that patients with coccyx pain, 77% has also back pain. And Berlin in 2006 said 71% with coccyx pain also have back pain. The groups are too small, and but it shows that coccyx problems often get back pain problems. And I see it also in my pelvic practice, but also vice versa. When I see back pain, patients with back pain, it still comes again, and then at time it's better, and then the back pain comes back. When I research also the coccyx, then it hurts much. It hurts often when there are only low back pain problems, and the patient didn't say they have problems in their coccyx. But when I treat the coccyx, the low back pain also recover or will still better. So I think it's important to look also with patients with low back to research the coccyx. And in the literature, what it's known that coccydynia also gives pelvic floor problems. The pelvic floor muscles are more strained, or defecation problems, or spasm overactivity from the levator ani, or dyspareunia problems. And it's known from the systematic reviews. Just to tell you something about what I see each day and what I'm working. This was a woman last week. I saw her, and a woman, she has daily pain, PSK 100. So 0 is no pain, and 100 is the highest pain you have. Then she had daily PSK 100, and pain after sitting was 98 at the end of the day, and standing the same. Defecation was very painful, NPS 5, 0 is nothing, and the numeric pain rating scale 10 is the highest pain, and she had always blood by defecation, and sexual activity was 9. I did by her, I did first the history and then the measurements, and then I did only the Neuromodulation. And after 3 days, she phoned me and she said, Sietske, it's much better. I can sitting much better. I can laying much better. I go to toilet with defecation, no problem, with no blood, but standing still gets much pain. I can't stand at this moment. So I told her to relax, and later we will go further. So it's first important to treat the coccyx, just what I told, and after that it's necessary to look what different tissues also can give the pain in the coccyx. And then it's important to look to the periost, to the muscles, and to the fascia. And periost can give coccyx pain, and also complaints, maintaining the complaints from coccyx pain. When can periost pain started? That's a possibility directly after a trauma, because there's directly a trauma from the periost, but it's also indirectly irritated by overload through continuous pull or pressure from muscles, ligaments, or fascia. And periost, what is the treatment of periost? It's very important to stop the pull and the pressure on the coccyx. And how you can do it? By relieving the coccyx with a towel, a cushion, and look for a good chair. And for a towel, you put a towel folded on the chair, 5 centimeters from the backrest. So the tubers rest on the towel, and the coccyx is free in the space. So it's important to have the coccyx free in the space, but also important to have the tubers, they can rest somewhere. So you have a steady state to sit. And the other thing that's very important is to relaxing the muscle of the pelvic floor, the buttock, the legs, and the abdomen, because when the muscles are contract or they are strained, they pull on they give pressure on the coccyx, and in that maintaining the complaints. And the other thing is pain avoiding when sitting. And when it's not possible for sitting, then it's important to the patients to go laying or standing, and also relaxed. So relaxation is very important. And the other thing by periost problem is to give painkillers. The muscles are also can get problems on the coccyx and maintaining on the coccyx pain. Here you can see the muscles who are inserted on the coccyx. Here the same place Jason Woon just told. The coccydius, the levator ani, the gluteal muscle, and the sphincter ani, they are inserted to the coccyx. So when those muscles are contracted and the coccyx still has pain, the pain stays there. So it's very important to relax the coccyx. to relax the muscles. And the muscles who are directly from the coccyx, that are the sphincter ani and the levator ani. But it's also important to look to the obturatorius internus because it can also give a pain project on the coccyx. And the same is also with gluteal medius, the gluteal maximum, and the piriformis muscle. So it's important to look to all those muscles to treat, because trigger points then are, when there are trigger points, there are noduli in the muscles and they are stiff and they are hard. And you have to relax them so there is more space and more movement. And there are more trigger points who also can get pain to the coccyx, and that's the quadratus lumborum, the deep back muscle, and also the abdomen muscle can pain on the coccyx. So it's very important to look total to the patient and not to look only to the coccyx region. What's important when you will look to the muscle to treat, the same, you also want to stop the pulling on the coccyx by relaxation of the muscles from the pelvic floor, the buttock, the legs, and the abdomen. And I tell always all the, also the buttocks, the legs, and the abdomen, because patients, it's difficult for them to relax only the pelvic floor. They don't know where it is and they only feel pain. So mostly I start with a relaxation of the legs, of relaxation of the abdomen. Again, pain avoiding when sitting, and if not possible, then laying or standing. And treat the trigger points by manual pressure, the tennis ball, a silo pen. Later the day I will tell more about it, or dry needling. Or walking to get a better blood flow, local and total. So the muscles will be better, get a better blood flow and get more relaxation. And when there is no pain while sporting, please go sporting. And stretching of the muscles without pain, because you want to relax. And the third thing, but very special, very important, this is to look to the fascia, to the connective tissue. And the fascia can also get pain on the coccyx. What's fascia? Fascia is the skin all around the body. We all have, our body is mostly fascia. Fascia is between the muscles, so the muscles can move between each other. And the fascia is in a muscle, around the muscle, around the muscle fibers, and fascia go through the tendon from the to the bone and to the other muscle. So all muscles are together with the fascia. When one moves, the other muscle moves also. And in the fascia that exists out from ground substance, and it exists out glucosaminoglycan. I don't think I'd say it good in English, but that's very difficult for me. Those cells in the fascia attracts water forming and attracts a hydratic gel. And this gel is responsible for the turgidity and the viscoelasticity of the ground substance. And water is also necessary because the gags, they attract the water. And when we look to the fascia, that it's changed constantly. And when it don't move enough, you get a dehydration and a densification, just as you can, it's showed at the picture. And it's very important to have in your body a smooth fascia. By increasing movement and hydration, you have a smoother fascia, and so and you get a reduction of stiffness. But when you don't move enough, or you have too much pain, or you don't drink enough water, the fascia will become stiffer. And when we look to now, you have to think with me about the next pictures. When we look on the back side, and you all know these pictures, When we look to the backside, you see the different layers of muscles. And when you can imagine that between the muscles, between the different layers, there's no movement, you can imagine when someone will bow that there will be, I will look if it's possible to show. No, when you look to the coccyx and you look to the muscles, when you bow down, you can imagine that all those muscles work together without movement between. And when you go bowing, then there's much pulling, much compression on the coccyx. So it's not only important to look only to the coccyx, but also to the totally fascia from the body. What's important for fascia treatment? It's also important to relaxation, because while you constantly have straining in your muscles, you get more pain, and the pain still holds on. But also abdominal breathing to relax more. Fascia massage to relax the fascia. A total body movement. So the total body will be better movement. There's not so everything will be smoother. A hydration, posture advice, and training while the body temperature is rising. Because when you are training and the body temperature rising, you get smoother fascia. You can imagine when you have paint, and the paint, when you will start with painting and you have paint in your, then you first have to stirring much, and then the paint will be softer, will be smoother, and then you can paint. And that's the same by fascia. I have a discussion, and for later, treated after trauma has a statistically significant better satisfactory story compared with others. Possibly there are more changes in the tissue of the body when the pain comes spontaneously or shorter. And possibly when there is also back pain, it is harder to treat. Maybe something for later. And the take-home message, treatment starting at the tissue. First, look at the position of the coccyx and treat if necessary. Relaxing, alternated with activity, and always within the pain threshold. Thank you for listening to me. And I think the coccyx is the cornerstone, but I thank you all.
Thank you very much for this very interesting lecture. I'd like to start with a question of my own. In your experience, the NIMOC technique, is it the results, are they comparable or even superior to the, I'll call it traditional rectal repositioning of the coccyx?
Yeah, I think, in my opinion, is better because I can do both. But rectal is more painful, and you can feel it. Yeah, there are better results, and that's why I started with the mobilization.
Okay, but
for me.
But if it fails, then you use the transrectal approach. Okay, thank you. Okay, there's a question from John Miles, please, Mr. Miles.
Hi, thank you, Siska, for that. I was interested, you mentioned dry needling, which I read about some time ago, but I haven't seen anything about it recently. Can you explain what the mechanism of that treatment is?
Yes, when you do dry needling, you do a needle. You put a needle in the muscle, and directly the muscle relaxated. And I think that's because there's a better blood flow, and when muscles are contracting or cramped, then you have filaments, you told, actin and myosin, and they are in each other. And to relax the muscle, you need kalium, magnesium, calcium. Because the muscles are contracted, there's no blood flow, and the blood takes those cells within. And when you do the dry needling, there will be a better blood flow, and with the blood also the cells, and then you directly has a relaxation. I've also I developed a silo pen. This one I will tell you later more about this. That is the with no fewer pain. You can also with the silo pen you can the muscle, you can treat the muscle.
When I read about it before, it was something that was repeated frequently. Is
What?
that something that you do?
The Neuromodulation or the
dry needling?
The dry needling.
Yes.
Mostly it's important to do the dry needling, and then it will be a little better. And then you also massage the muscles and also treat the fascia. And then every time it will be a little better. And relaxation of the patient. I think that's very important to teach that, how to relax and how to sit. And
okay.
It's together. It's not only dry needling, also more.
Thank you.
Dr. Foy, please.
Hi, another excellent talk. Thank you. And nice to see you again. One of my questions, I guess, in terms of the non-invasive or external approach as opposed to internal, does it depend upon the position of the coccyx? So, for example, if the quote-unquote problem was that the coccyx, is subluxed or moved significantly anteriorly or forward, would that be more challenging to reposition that with an external approach where theoretically having the finger inside the rectum and pulling posteriorly mechanically might be more in line with the correction?
No, that's not the most difficult, but more difficult is how to find what's the position is. That's difficult. The movement, that's now when you know what's the problem, which side the coccyx, when you know which side it is, then the movement is the same, but which side the coccyx is and what the position is, that's more difficult.
Okay, thank you.
There's one more question from Ms. Zedig, please.
Ja, hoi Siets. Ik heb een vraag. What would you do first? The Nemo or the dry needling?
She asked what I do first. Dry needling or Nemoc mobilization. First, I do always the Nemoc mobilization, and sometimes when the muscles are so cramped, then I use mostly the silo pen to relax the coccygeus muscles, and then I do the Nemoc mobilization again. But mostly in the first treatment or the second treatment, I do first the Nemoc mobilization.
All right, I understand. I do the same, but when I think about it, when the muscles are more relaxed after dry needling, Nemoc may be more sufficient.
Yes, but when the coccyx is not in line, also it will comes back. So I believe when the shoulder is subluxated, it's important first to put the shoulder again back. And I think with the coccyx is the same, but there are more roads to run. So.
And I have a second question. How do you stretch the pelvic floor?
Sorry, I don't understand you.
How do you? Can you hear me? Or no?
Connection is really bad. There's some noise in the background with your mic. I don't know what it is.
I don't know either. How do you stretch the pelvic floor? Hoor je niet?
Maybe if
how
you
do
want
stretch
to
out?
type it maybe in the chat, that's probably
I think
Oh,
the
yeah,
question was,
yeah.
how do you
I'll-
stretch the pelvic floor?
Yes.
How do you stretch it? Was that the question?
Thank you. Yes.
Stretch.
Yes.
You can stretch the pelvic floor with a towel in the pelvic floor and no pressure on the coccyx. And it's important you can with the abdominal breathing, and you can put your finger under the tubers and then ask the patient to relax, and then your hands, you put in your hands. Mhm.
okay. Thank you very much. Final question by Dr. Knobloch, please.
Yes, Sitzke, thanks for an interesting presentation. In Norway, we have a lot of coccyx injuries because people are going skiing and then they just fall down on the ice. And these patients, if you examine them from rectum, then it's often you have a quite amount of pathologic mobility both ways. And my question is, if you have an injury of the disc CO1, CO2, and you have injury of the ligaments, how do you maintain, if you reposition the coccyx, how do you maintain the position? Because my experience is, if I treat them for 1 year with injections, then it doesn't heal. So the problem remains the same.
What I see is the first thing is to give a reposition of the coccyx. And I think when the coccyx is in line, then it will stay mostly in line. I don't see patients, I have to treat a longer period. First, the coccyx reposition with the NIMOC, and then I treat also the muscles and learn the patients to relax and contract the muscles. And when that's possible, they don't come back because or they had to fall in again. So I think injection.
Is it an option, Rainer, that in the phase that you see them, that it's a more acute and there is a fracture, that first a fracture need to heal before we can work on it? Or do you see them in a very late state?
I see them after 2 years, perhaps.
Yeah.
But as you know from John-Yves and Levon, it's just 9% of all the injuries are fractures.
Mm-hmm.
So the most injuries to the coccyx are in the disc space, the annulus fibrosus, and in the ligaments.
Yeah. But our experience is a little bit that the sooner we get there, the sooner we see them, the sooner we can do a NIMOC if there is not a trauma. So we could exclude that. That's the reason why we want to have an X-ray. The sooner we can put it back in place, the less injury is there in the areas around. So if you see them after a couple of years, you can imagine that the whole chain of movement is getting worse, and then we have to do a lot more work than if it's happened a few weeks ago or even the day before.
Then it's also important. Then it's also important to treat the fascia because when you don't treat the fascia, it will give pull on the coccyx with the coccyx pain.
All right, thank you very much for this very vivid discussion. Now I would like to continue with the next lecture, which is my own lecture. So I will talk about neuromodulation in coccyx pain. Let me start it up real quick. All right, very good. Okay, so I will talk about neuromodulation. Neuromodulation, for those who are unaware, are basically different techniques that all have the same goal, and which is to manipulate the neural pathways, both the activating pain pathways that go from the peripheral nerves to the brain over the spinal column, and also to activate pain inhibitory pathways that work the other way around. So it's a very versatile set of tools, and I will not go into total technical detail, and I will moreover concentrate on two patient presentations as two examples of the possibilities of neuromodulation. So this is basically a selection of different interventional therapies. I will not talk about the intradiscal application of corticoids or the impaganglion blocks. Dr. Foy will talk about that. And I will also not talk about diagnostic blocks, which we do, of course, apply before we do more invasive treatment. Dr. Thoma is going to talk about that in a different lecture. And I've lined up some different or the main techniques of neuromodulation here, and it starts with lesser invasive techniques such as pulse radio frequency that can be basically applied to any neural structure. In this case, of importance for us, the sacral roots and the ganglion impar. And then we have the SCS, the spinal cord stimulation, which is the most traditional technique that goes all the way back to the late 60s. We have the DRG, which is the dorsal root ganglion stimulation, the SNS, the sacral nerve stimulation, which Dr. Demmel will talk about tomorrow, especially in respect to the pudendal nerve. And then we have the PNS and the PNFS, which are basically the peripheral nerve stimulation and the peripheral nerve field stimulation. The difference being that if you have a named nerve, like the median nerve, for instance, or the tibial nerve, then you call it PNS. And if you don't, if it's just a circumscribed pain area, you call it PNFS. And then, of course, we have the coccygectomy, which Dr. Knoblauch will talk about tomorrow as an even more invasive therapy. So the first case report, as a female patient, 35 years old, young patient, presented with coccygeal pain after excessive spinning exercise. She described the pain as being present when sitting, with build-up over time, depending on how long she would sit, and also with an increased stand-up pain. She described the pain as piercing. She literally said, it feels like when I stand up, it feels like I'm getting stabbed by like 5 knives. And the intensity would also increase depending on how long she was sitting. She could trigger the pain. Also in the examination, it was easy to trigger the pain by applying pressure to the coccyx. And this was also true when lying in supine position on a harder surface, for instance, the MRI table. She described the pain as 7 out of 10 on the numeric rating scale, 10 being the maximum, which was also the case when she had the piercing pain when she was standing up. She had a significant impairment in quality of life. Of course, you can imagine such a young patient not being able to sit is very bad for her quality of life. And her prior treatment included, but was not limited to, superficial coccyx infiltration by orthopedics. She consulted numerous orthopedics, which is also a very common thing. She had osteopathic treatment, she had physiotherapy, and also osteopathy and alternative medicine treatments. Medication, she took the usual NSAIDs only occasionally. It provided a mild relief, but was not a game changer for the patient. So this is the way she localized the pain in the coccyx area with radiation to the lumbosacral area, similar to what we just heard, and the combination of coccyx pain with low back pain. So we performed, we talked earlier today about problems with radiologists getting a proper x-rays in sitting position. This is also true in Germany. So in this case, we did it ourselves. This was done with an older x-ray, as you can tell, but still what it showed right in the middle of the picture that there was basically what we would call osteochondrosis on the spine between the sacrococcygeal junction. She then received an intradiscal corticoid application and transdiscal infiltration of the imparganglion with contrast agent application. Again, I will not talk about this in detail now because Dr. Thoma will talk about this in his lecture. And that yielded a significant improvement in pain, 85%. She was almost pain-free. Only prolonged sitting still triggered the pain. So she went on to receive a total of 7 injections over 14 months, which always had the same result, more or less. It provided the same amount of pain relief for 4 to 8 weeks, depending on the activity of the patient. And then something happened, which we also touched on earlier in a lecture. She had a pain exacerbation after the last injection, and she had to be hospitalized for that. We performed an MRI that did not show signs of osteomyelitis, but it showed a mild periostal edema. So she received another injection, this time at the dorsal coccyx itself. So basically in the area where the pain was localized. It did improve the acute pain, but it took almost half a year for the pain for the new pain, I'll call it that, to subside. So after that, of course, we were reluctant of continuing with injections. So we took the next step and performed pulsed radio frequency of the imparganglion. So this is basically from the technique. Again, I will not touch on this too much now because Dr. Foy will talk about invasive techniques, but it's basically performed in a similar fashion as the block of the imparganglion, only that we apply radio frequency, pulsed radio frequency, very important. This is 42 degrees centigrade. It's non-destructive. Not to be mistaken with the radio frequency of the rami dorsalis, yeah, it's 5-minute pulse radio frequency with 20 millisecond pulse width, and this also had a very similar result. Only that, and this is typical for this technique, that the results are comparable to the infiltration of the imparganglion, but the pain relief lasts longer. Usual, and this was the range here was 2 to 4 months. Also, the activity of the patient also always played a role. She was young, she wanted to work out, she wanted to do sports, but also the placement of the needle, of the tip of the needle, plays a vital role in the efficacy. So the question that arises now for this patient is, what's next? Okay, do we keep on doing the same thing again and again? Again, she's 35 years old. 37 now, so she's still very young. So this is not a permanent solution, it seems. So what's next? Do we do a radio frequency thermal lesion of the coccygeal, of the dorsal rami of the coccygeal nerves? Do we perform a sacral neuromodulation? Even a dorsal root ganglion stimulation of the lower sacral roots, S4, S5 maybe? Or a sacral nerve stimulation. So this is basically the question at this point where we ask ourselves, how do we keep going with this patient? This is something that we might be able to discuss. So the literature is very sparse on the topic. It's very hard to find anything that is. There's this publication here from a Turkish group from Istanbul who applied the radio frequency at the ganglion impar. Yeah, but there's only very few reports on these invasive techniques. So the next patient is a male patient, 55 years old. He first presented in May 2016 and had coccyx pain since the early 90s. Okay, so he had a partial coccygectomy in 1996. And his pain was also increasing in supine position when pressure was applied to the coccyx, and also in the typical fashion when reclining in sitting position. His pain on the numeric rating scale was 8 out of 10 in supine and reclined position and 4 out of 10 when crouched. And he also had nightly pain attacks. They were rare, but they were recurring every 6 to 8 weeks. The pain was localized at the coccyx and at the sacrococcygeal junction. And he only, same thing as the patient before, he achieved mild pain relief with NSAIDs and low-level opioids. So again, this patient had an injection of the impar ganglion, but this time it did not help him. It caused a pain aggravation. Then he received more conservative treatments. We tried tapentadol, which is a mild to moderate opioid mimic drug. Basically, it had severe side effects. He had dizziness, fatigue, and nightmares. So the medication had to be stopped. We then sent him to a multimodal pain therapy of 2 weeks, which helped him with coping with the pain, helped him in terms of relaxation techniques. Physiotherapy helped a little. So everything, it made him feel better, but the pain itself was not really changed. So he received a pulse radio frequency of the S2 to S4 nerve roots. This is done through a transhiatal axis with a probe that has a tip that is steerable, and it allows to enter the sacral space and steer the electrode towards the roots. And this yielded a 50% pain reduction. So we went one step further and implanted an SCS lead with 8 poles for a trial stimulation. And that had a very good, excellent pain reduction from NRS 8 to down to NRS 1 out of 10. So basically 90% pain reduction. The trial usually lasts a couple of days. So after the trial, the electrodes are cut off. And then he received 1 month later, he received the IPG implantation, so the neurostimulator, after the successful trial. And this patient has been almost pain-free for like 3 years now. Okay? He is very, very happy with the stimulation, and he does not want to live without it anymore. These are the X-ray images. You can see the 8-pole SCS electrode here. It was done through a retrograde puncture of the epidural space in L3, L4, and then the electrode was lowered down into the sacral space. You can see in the side projection that it's going all the way down, almost to the hiatus. And this is very important to note, because if you put it too far, like into the hiatus, it can cause horrible pain to the pelvic floor. So it needs to be inside basically of the hiatus. Okay. So what are other neuromodulation techniques? And I will talk about the pitfalls and the considerations that have to be done in a moment. So this is just a collection of different techniques. You can see on the left side the classic SCS with 2 electrodes. Here, this is in the lower thoracic spine, and it's also interesting because there has been the idea of stimulating the conus medullaris, also to reach the sacral nerves or the coccygeal nerves. In the middle, you see classic DRG, dorsal root ganglion stimulations. That can be, this image here shows L3, L4, L5, and S1, but it can be done in S2, S3, or even very difficult, but possible in S4 as well. And the image on the right is the image you just saw from our patient with the electrode in the sacral space. And of course, what I'm trying to say is that anywhere you have a nerve, you can perform neuromodulation. So this is an example of what's it called? Excuse me, infrapatellar nerve, or another example here, suprascapular nerve. Okay, not important for our subject today, but it's basically to get the idea that wherever you have pain, wherever you have nerves, you can apply neuromodulation. But it wouldn't be the pelvic region if it didn't have some pitfalls and some considerations that are very important. And there's this very nice publication from Corey W. Hunter. It was published in February this year, and it explains very nicely what the challenges are. And the challenges come as often with the anatomy and the nerval innervation of pelvis and the coccyx. And basically the results that they had that line pretty much up with the results we have been seeing is that some patients benefit extraordinarily well. They're very happy. And then there's patients that do well in the beginning, but then they lose either the effect, or what's even worse is they get overstimulated and they have more pain than before. And it's very, very difficult to get these patients back to a point where they have pain relief again. This is different to the traditional spinal cord stimulation, where an overstimulation can happen, but it's rather easy to achieve the initial pain relief again after turning off the stimulator for 2 weeks. There seems to be a very high sensitivity of the sacral nerve roots that also is very important when considering how you stimulate. So basically we use SCS equipment, but you have to think more like a DRG, like a dorsal root ganglion stimulation, which means less voltage, less amplitude, less smaller pulse widths. So this again is attributed to the very sensitive nature of the sacral nerve roots. So they also had the same issues, what I just talked about. And so the explantation rate is higher than in traditional SCS. And the results seem to be either very good or not as good because of these pitfalls. This is one of the problems. And the other problem is, of course, the anatomy. And they talked about this in this same group. They talked about the dorsal root ganglion stimulation for chronic pelvic pain. And they found out that placement in S2 and L1 yielded the best results. And now you would ask, L1, why? This is so far away. But if we look at this chart that shows the lumbar sacral plexus, it shows that L1 and S2 basically cover most of the nerves to some extent that come out of the lumbar sacral plexus. And this is probably the reason why they had the best results there, but it also shows that how important it is to know where the pain is coming from and how important it is how you can manipulate the pain. So diagnostic blocks play a vital role, for instance, in finding out the proper target. So this is very, very important to choose the targets wisely. Yeah, and this is another slide for the complexity of the neuroanatomy that shows that from different kinds of the spinal column, the pelvic floor and the pelvis itself are innervated. You see you have parasympathetic innervation from S2, S4. You have sympathetic innervation from TH12 to L2. And you have the pudendal nerve from S2 to S4, and also the S3 innervation of the dorsal perineal muscles. So very complex, and this is something that is nothing to begin with when you do neuromodulation. So this is more advanced, and it requires a lot of thinking and considerations that are not so important and not as vital in a traditional SCS, for instance. So the take-home messages are that neuromodulation is a very versatile tool. It can yield excellent results when applied correctly. Always keep in mind that different nerves can contribute to pain in a given anatomical area. The application of neuromodulation is more challenging, more daunting than in others, for instance, spinal cord stimulation, both in technique, I mentioned before, the retrograde puncture of the epidural space, and complexity of the underlying pain syndromes. Good preparation, for instance, diagnostic blocks, do significantly increase the rate of success. And the sacral nerves, as mentioned before, are very, very sensitive, so tread carefully, use low amplitudes. Thank you very much for your attention. And now I hope we can get a vivid discussion as we had before. Thank you.
I'll start if I may.
Yes, please go ahead.
Sure, thank you. Another fascinating talk, thank you. One of my questions is, what are your thoughts as far as radio frequency neuromodulation basically at the caudal space, where some of the somatic nerve fibers are exiting. I think I saw one study, and this is a few years ago, about using it for patients who had persistent pain post-coccygectomy. But theoretically, the approach could be used in non-coccygectomy, coccydynia patients as well.
It's basically what the one study that I showed from the Turkish group did. They treated the dorsal rami like they would like in facet joint pain in lumbar spine. So we have not performed this yet, but it is a consideration. So yeah, we have not really done it yet, mainly because the classic radiofrequency is destructive, and we were probably a little afraid of causing more damage there. But you're absolutely right. I mean, it is a consideration that has to be done as well. But usually, if you are able to achieve good results with the pulse radiofrequency, yeah, it's.
I may have misspoke if I said destructive. I was talking about the radiofrequency neuromodulation, the non-ablation. Basically, almost like you would go to do a caudal epidural, but instead you're doing a caudal approach to a radiofrequency neuromodulation, not destructive, not ablative. I've done a few, and I can't say that I've been overwhelmed with the results.
But the ones you did were outside of the hiatus, right?
Basically, just at the base of the sacral hiatus, basically where you would, just at the entry point for, as I say, like a caudal epidural.
No, we haven't done that ourselves yet either. So we did what I said before, the transhiatal pulse radiofrequency, but not outside yet. I'm not sure if comparing it to the stimulation that we did with the spinal cord stimulation probe. We saw some results that when we showed that when we put it too far downward, so that it would be inside the hiatus, like let's say inside the tunnel, then it would cause paresthesias and even aggravate pain. So I don't know if the result would be similar here, because it might not if it's outside, like you just said, but I honestly don't know. We haven't tried it yet.
Thank you.
Dimitros?
Yes, please.
You were presenting to patients.
Yes.
With a kind of cry for help. It's not meant as arrogant, but have there been any conservative options in the past? Because I think we need to work together. I don't know how we should fix it, but we need to work together, that everybody here also has this basic mobilization techniques in their fingers. And I think Sietske will very happy to learn it to you, because there is a lot of work to go on in the chain of movement in the whole body. And if you want to treat, and that's my experience, if you want to treat one point and you're not solving the rest, this point will come back and back and back. So we need to work on, with fascia therapists, whatever, to work on the whole system, to give the coccyx area even a chance to recover a little bit. Because the change of movement that we do with that neuromobilization is so small that we sometimes even do not understand exactly what we are doing. But we see the most amazing results sometimes passing by that we even can't explain. So we are step by step now preparing the research here at the University of Groningen, and that we are very happy to have that chance. But if the chain is not okay, if there was a lot of trigger points, whatever you want to call them, it is, for me, rather logical that the pain will keep on. Furthermore, what I see when I walked here with our anesthesiologist, when I saw the treatments, and especially when they put on the lights, the fluorides on the X-ray, so that we can see where the injection is going to be, we see a lot of spicula often on the anterior side pushing in to the water ganglion, and that cannot be solved. And then you really need to have something permanently to decrease the pain there, because this nice shape of the bone is then pushed in with some spicula, what will activate the pain time over time. So the protocol we have been working on since Dordrecht, based on all the discussions we had with everybody, is the startup to take care of the whole chain of movement. What is your opinion about that?
I totally agree with that. But the point is, and this is something that really is difficult, that very few physiotherapists are specialized in pelvic physiotherapy. And so the patients, when the patients come to us, it was like the flow chart Ms. Loho-Venema showed, we are at the very end of that, right? So, when the patients come to us, they've already had all different kinds of physiotherapists, some have seen 5-6 different ones, and none could help them. None could alleviate that. And this might be because they lack the proper education. I totally agree with that. So, but this is a very difficult problem to solve.
Well, I would suggest, and I'm looking also to Dr. Main and to Reinhard, if we make plans for a future conference in perhaps another 2 years, and also looking to Sietske, is it an idea that there is a day before the conference that Sietske can train you, because it is a very easy way to do so, that you have this technique at least in your spectrum of treatment. So if we are really hoping that we can come together again, as we did in 2018, we did a masterclass in advance, but we can do a training like this also. We probably go to Turkey, so that's covered, but for the rest, there are options that we can learn it to your physios, or if you want to yourself. So it's not a very big investment on time, but it could really help your patient, because if that coccyx is not in the right position, it will keep fighting again that it can't be solved.
Well, yes, of course. I mean, I would love that, but the problem is, how can, I mean, as you already said, the problem is in the system, right? So how much will it help if 2 or 3 people learn it, if we cannot, you know, spread it so that people don't come, I mean, a lot of people come traumatized. They say, yes, he did something transrectally, it hurt like hell. And like 2 days later, it was the same as before. And so the people, they have already lost their patience. This is also a very big issue. So,
well, I don't say it's easy solved, Dimitros. I really don't think so. But if we don't make this step, it will never happen. So we need.
I agree. I totally agree. I totally agree.
You know, we start the movement in our Coccyx community that we have by now, and perhaps we must also take that conservative options in account, that we have enough people around us, and especially for the specialists, that they have them around you, that you at least can find out if that is the issue, and if not, then you know that you have to go further and you have to take your next steps.
Mareike, we planned this, but the COVID pandemic cut this strain. We did other things, planning this Coccyx symposium last year, we planned a masterclass before, but.
Yeah, I know, but it didn't, and it's not nobody's fault. This is the world that we are in right now, but I'm still hoping that things are getting better. and that there will be a time that we can meet again. I will stay positive.
I agree with you. And let's go on in this plan. So if you go to Turkey, it's near to go to Munich.
Yeah, well, that's a very good plan.
Yeah?
Very good plan. We love to come.
All right. There was another question in the chat by Dr. Ibrahim about the reimbursement. I'm going to answer that real quick. For the SCS methods, this can be, the reimbursement is the same as with a regular SCS. And with pulse radio frequency, there's also a reimbursement, which is can only be done in the clinic, though. It can't be done in a private practice because the costs outweigh the income. But there is a reimbursement. It is not always easy. It is shaky at times for the pulse radio frequency. So, but we haven't had too many problems lately with that. They are focused on other things right now. Mr. Miles, please, one more question.
Yes, it wasn't actually for you. It was a point raised by Marika and relates to Siska as well. And it's about publication of trials of the success of these methods. And it seems to be a lack of good published trials of manual therapy. And there's a lack of good published trials for many treatment options, and I'm not aware. Have you got published trials of NIMOC?
No, not yet. And we are preparing it with the University of Groningen. We have a place there that we can start up to do the research. So I hopefully we can start it later on this year. And find our way in it. You know, we first had to train a lot of physios who were able to do these techniques before we can do any research, because you can't do it on your own. You need to have more physios so that you have more multi-center effect. So we first want to do a trial, and and hopefully that we will have more results in that time. But guys, it's the world from now, 2021, that physiotherapists in my country are not learned anything about the pelvic floor. They don't have a clue. Manual therapists are master manual therapy education. Most of them do not learn anything about the coccyx. It's really finishing by the SI joints. They do not learn anything about the coccyx. And if you ask them, they say, oh, yeah, well, we have to make a skip somewhere. And they just literally skip the whole coccyx. So we are still working on this area, and it will take time. But I think this group, Coccyx community group that we have now, is the first group that can spread the word in different countries. And it's more that, you know, that Siets and I will be very happy to share our experience and knowledge so that we have more and more experience elsewhere in the field. Okay, I think once you do publish a trial, then that will be very helpful in spreading the word. Yeah, absolutely.
All right, so one final question by, again, Dr. Knobloch.
Yes, Dimitrios, just I would like to know the case report, the first. You did use a lot of triamcinolone, and as we know from John-Yves and Eilif, we have had some blanching of the skin. And did you use a lot of these injections in this patient? Do you talk to the patients about the risk? Or did you have subcutaneous atrophy in this patient?
We did not, thankfully. We are considering changing the corticoid because of what you just said. We do talk about the risks, of course, but thank God, until now we didn't have any problems. But we are aware of the fact, and we are considering changing it.
Should I ring CT to get that CT sooner? That woman, mate. No bother.
All right, so we're a little over time, so I think we need to keep going. Is Dr. Angermuth online? I don't see her right now.
Yes, yes.
Oh, she is there. Very
yes,
much. Okay, very nice. Okay, so I'll give a short introduction.
I start the video. Okay, you can see me.
Yes, I'll give a short introduction. Dr. Angermuth is the chief resident of the neurourology department of the Schönklinik Vogtereuth, which is a small city outside of Munich. She studied medicine at the Technical University of Munich and went on to work in the city hospital of Bogenhausen, which is also the hospital where I come from. She was then a chief of medicine of a surgical clinic specializing in pelvic pain and neurourology, and has extensive experience in consulting different hospitals in and around Munich for the neurourological topic, and she will talk about the neurourological aspects. Yes, and we're very happy to have you here today, and with no further ado, the screen is yours, please.
So I'm happy again, and I have the honor that I can talk to you as a urologist in this very fine and complex symposium. I'm very delighted, and I hope, for on the one hand, that I don't bring sand to the beach for you, but on the other hand, I want to give you a short glance out of the box, because I don't speak about pelvic or about bladder pain syndrome. That is normally then when I talk in a setting like this, we talk about bladder pain syndrome, but I will talk about the neurological aspects of cauda equina and the peripheral neuropathies. If you see these pictures, you can imagine that any lesion in this area, in this region, can affect the neighboring organs. So first I talk about the tasks of the urinary bladder. First, it's the storage. The storage is the safe storage of the urine, and and the other thing is emptying, and the emptying should be in the right place and time, with low pressure and without residual urine. This is the maxim. So in our neurourology settings, in our the small commune also, we differentiate first into disruption of storage functions. These are the symptoms, the signs, the clinical presentation. And if the storage function doesn't work, there is a result incontinence. And if there's any disruption of emptying function, then we will perhaps have residual volume. But mostly in neurologic lesions, there are mixed forms. If I have only the clinical presentation, I can't say something about the function of the bladder and the pelvic floor. So I have to look into this black box, and I will do this with urodynamic tests, mostly in video urodynamic tests. I don't know if you see the graphic here totally, because the pictures are over this, but there's a graphic. It's very, very, very simplified. It's from Madersbacher in Innsbruck, and there is shown that there are different states that can produce incontinence or residual volume. First, on the left side, up top, in the top, you see the so-called detrusor sphincter dyssynergia. This means that the emptying of the bladder is not synergy, it's no coordination. And so the detrusor and the sphincter work against each other. And the pressure, the high pressure, has to go somewhere, and it goes up to the kidneys. And on the right side of this picture, this detrusor sphincter dyssynergia is mostly the result of lesions of the upper motor neuron lesion. So we learn it. And on the right side, we see overactive detrusor with normal or impaired function of the sphincter. This is often the result of cerebral, of suprapontine lesions. And in the other pictures, we see two pictures with underactive detrusor with different levels of sphincter activity. And this is what we learn, that this will be the result of any lower motor neuron lesion, as like coda equina or with peripheral neuropathies, but it is not so easy. It's more complex, and I won't show it now. This is only the distribution, how we explain, or we say, okay, I have a spinal cord injury and it's very simple, and if it's an upper motor neuron lesion, there is this result, and if I have a lower motor neuron lesion, there is this result. But this is not so, and so I will show you more. It was explained by the former speaker that there are two nerve systems that are responsible for the innervation of bladder and pelvic floor. The one is the autonomic nerve system. This is sympathetic innervation coming from spinal segments TH12 to L2, leading from the lumbosacral sympathetic chain ganglia to the plexus hypogastricus superior and form the hypogastric nerves, which synapse with postganglionic sympathetic neurons in the pelvic plexus. The special, especially in the pelvis, is that there are short postganglionic nerves that innervate the bladder body and the bladder neck and the proximal urethra. The consequence is relaxation of the detrusor and contraction of the bladder outlet. This is when we are in danger, sympathetic innervation comes, we have no time to make pee because we have to fight. The second one is a parasympathetic innervation from the spinal segments S2 to S4, and they are responsible for the contraction of the detrusor and the pelvic floor. The other part are the somatic efferent motor neurons, and they innervate the external striated urethral sphincter muscle and the pelvic floor muscle from the Onuf's nucleus. You have to notice that there is a combined activation of the urethra. One is of the sympathetic, comes from the sympathetic innervation for the sphincter urethra internus, the bladder neck, and the somatic pathway with a voluntary possibility to strain the sphincter urethra externus by innervated by the nervus pudendus. It elevates bladder outlet resistance and contributes to urinary continence. We have the efferent innervation. It is familiar to you because you're the pain specialist. So the pelvic, hypogastric, and pudendal nerves also contain efferent axons that transmit information from the lower urinary tract to the lumbosacral spinal cord. The small myelinated delta axon give the information about bladder distension. They say me, how full is the bladder? Can I go to the cinema or have I go to the bathroom? And for you well-known unmyelinated C axons give information about volume, chemical, inflammatory, neuropathic conditions, and the temperature. It is known, you know it, that during inflammation and neuropathic conditions, there is recruitment of C-fiber bladder efferents, which form a new functional efferent pathway that can cause bladder overactivity and bladder pain. So the bladder pain is often connected with bladder overactivity, like a bladder pain syndrome. So this is are pictures you know very well, but often there's a difficulty to explain it also for colleagues and for patients, that the spinal segment is not the same as the vertebral segment. And so we as a me as a neurologist, I always have the orientation that the TH12 vertebral segment is the region of the spinal bladder center, S2 to S4. And so we explain the upper and the lower motor neuron lesions. The structure of the cauda equina is, because of the human development, neuroanatomy of the spinal cord ends in the adult at the vertebral segment L1, but the spinal nerve still exit through the original segment foramina. The dorsal root ganglia remain at those segmentally determined levels. Following, the lumbar system is filled with the roots L2 to S4, and this looks like a horse's tail. And this is what I mentioned, difficulty to explain to the patient that there is a damage to the sacral roots S2 to S4 because of something which has happened at L4 to L5. I come to the cauda equina syndrome. The cauda equina syndrome, equina and the conus lesions may result in profound functional compromise of the bladder, the colon, the pelvic floor muscle, and even sexuality. The common acute causes of CES are first, disc herniation, the central one, mostly L4 to L5, L5, S1, you know it. The second one is traumatic injury, mostly spinal fracture, L1, TH12. And here, it's the height of the conus, we have a mixed presentation of lower and upper motor neuron lesion. This is special, and we have to think about this. If there is any lesion at this, a trauma in this region, that is not so predictable what the results will be in the functional. There are also iatrogenic conditions following surgical or medical intervention, like spinal anesthesia, hematoma, edema, and injection. The common chronic causes of CES are spinal tumors, spinal stenosis, it's very modern illness, spinal stenosis, inflammatory conditions, infectious conditions, arteriovenous malformations, and the spinal dysraphism. What are the symptoms? What are the urinary symptoms? First of all, there's always, in a great number of patients, a disturbed bladder emptying, sometimes with complete urinary retention. But there's also incontinence. This may be a result of overflow due to poor or absent detrusor contractility, or due to lack of resistance at the level of the external sphincter. Both, yes? And we have mostly an impaired sensory, and a lot of people, and we often forget this, have also urgency frequency. It's due to detrusor overactivity. The reason is because following the loss of parasympathetic innervation, preganglionatic sympathetic nerves re-innervate the parasympathetic ganglion cells, and as a neuroplasticity. So notice, low sacral cord and cauda equina lesions may produce an insensitive, decentralized bladder with poor compliance or detrusor overactivity, as well as an underactive detrusor and urinary retention. What are the consequences for the bowel? Don't forget the bowel, I always say it, yeah? Constipation from the first day of the lesion. Yeah. There are different causes. we have to think also of the pain medication. I come to this issue. And there will be often anal incontinence. And the anal incontinence is not only because of deficiency of the anal sphincter, but it can also follow a constipation because of impaired emptying with overflow or flow or paradoxical diarrhea. The sexual dysfunction is a very bothers the patients very and reduces the quality of life. And unfortunately, the sexual dysfunction is one of the topics that are often remain after coming back. The motor function, the constipation is better, and the urinary function, but the sexual dysfunction may remain for a long time or forever. The signs are diminished saddle and genital sensation, erectile dysfunction with diminished erection or inability to obtain, it's too short, in both women and men, orgasmic dysfunction, and in women, diminished lubrication. And if you see these, I go to the peripheral innervation, and if you see this graphic, you can also see what there is a complexity of the peripheral innervation of the pelvic organs. And you can imagine that any kind of lesion can cause major disruption of function. So I will tell you some of the causes. Metabolic disease, diabetes, infectious disease, for example, herpes zoster, degenerative disorders, and systemic illness. I will focus on surgical procedures and radiotherapy. The surgical procedures mostly are the abdominoperineal resection of the rectum, the hysterectomy, mostly because of a widened operation with, if someone has a cancer, a gynecologic cancer, the radical prostatectomy, and the bilateral ureteral reimplantation. The manifestations are voiding functions nearly always in the first time, incontinence depending on the amount of the pudendal nerve injury, pain, and erectile dysfunction. Nowadays, optimized neuroanatomical knowledge, identification of neuronal structures, and new nerve-sparing surgical procedures improve the outcome of bladder dysfunction. So, named the robotic-assisted laparoscopic radical prostatectomy, and we can see also in the gynecology that there is, we know now that the simple supracervical or laparoscopic supracervical hysterectomy may be a less destructive surgical approach and may reduce the risk of post-hysterectomy bladder dysfunction. But sometimes, especially in the oncologic reasons, there will be not the possibility to operate nerve sparing because the aim is to cure the patient from his cancer. The radiation therapy is the other one that can harm the peripheral nerves in the pelvis. This occurs often years after the therapy. The reason is that the cell death may occur months or years later. And functional changes in the lower urinary tract have been reported after pelvic radiation for the treatment of prostate, bladder, rectal, cervical, and uterine cancers. The radiation therapy is characterized that even low-dose radiotherapy can inflict significant damage. The symptoms are mostly urgency, frequency, urge incontinence with decreased bladder volume, low compliance bladder, diminished detrusor pressure as a result of, on the one hand, end organ neurogenic injury and or afferent nerve denervation by perineural fibrosis. There may also occur stress urinary incontinence, and the risk for stress urinary incontinence increases over the time and is significant by 6 years after therapy. This is one of my favorite pathways I take because predicting, I do it for a lot of years, predicting urodynamic findings for individual cases on the basis only of symptoms and neurological examination is often impossible, and therefore therapy should be directed on the basis of clinical history and thorough urodynamic testing. So what's about the diagnostic? I take the history as normally, but I have to talk about also about bowel and sexual function, and you have to do it proactive to the patient because they don't tell it by themselves. Was there dysfunction prior to the surgery? Is there pain medication? What kind of medication? And there are a lot of medication that these patients take that influence the function of bladder and bowel, and what are the comorbidities. The best and non-invasive tool is the bladder diary, where the patient has to protocol for 3 days and nights what the amount of their emptying are, and if there's pain, is there any loss of urine, and so I can see a lot of things with this tool. The urine analysis is normally, I think. The physical examination is the first one. I tell my neurologic colleagues that they have to look at the anus. They have to prove sacral reflex arc integrity. Is there a laxity or a spastic of the anal sphincter and loss of the bulbocavernosus reflex? Is there the inability to activate anal sphincter? How is the genital, anal, and perineal sensation? Is there saddle anesthesia? The ultrasound can show me if there's any post-void residual volume and how the bladder wall looks, and or if there are any other pathologic appearances in the bladder. The best tool to look in this black box are the urodynamic studies. And with the questions, is there a functional or a morphological intravesical obstruction? Is there a detrusor hyper or underactivity? How is the sensation of the filling? Do they feel the temperature of the liquid? The management and the main goals of the lesions and the the dysfunction of the lower urinary tract dysfunction is at first preventing upper urinary tract damage. Most of the patients only want to have an improving of quality of life, but the preventing upper urinary tract damage is very important. We have to improve the continence, and we have to preserve the ability for rehabilitation, and not only rehabilitation for the mobility, but also the rehabilitation of the bladder, of the morphology. As a general rule, treatment of vesicourethral dysfunction after caudal equina lesion or peripheral nerve injury should be directed by the urodynamic findings. The conservative treatment is first the conditioning of behavior, urotherapy, and I will carry out that the so-called Credes maneuver is forbidden. This means that to squeeze out the bladder with the hand on the lower abdomen is very, very bad because it triggers a reflex contraction of the pelvic floor and the external sphincter, and then resulting in increased bladder outlet resistance and elevated intravesical pressures. Physiotherapy, we heard it, is also here very important. Manual therapy and osteopathy, and I can mention that in Germany there is a group of physiotherapists. They are specialized on the therapy of the pelvic floor. It's called AGGGUP, Arbeitsgemeinschaft Gynäkologie, Geburtshilfe, Urologie und Proktologie. And they have a very good education, and they are specialized also in detonization, in relaxation, and in manual therapy. Very important is ask for medication, because the medication is important. The anticholinergica we give when there is an overactive detrusor, and alpha adrenergic antagonist like tamsulosin we give when we think we have to make the way free to open the bladder neck. But there is no evidence, and this is always the question, that there is there's no evidence-based benefit of medication in underactive detrusor. This means that the golden standard is always the clean intermittent catheterization to empty the bladder. In the surgical treatment options, we see the botulinum toxin A injection in the detrusor and the sacral neuromodulation, botulinum toxin A injection for the overactive detrusor, and sacral neuromodulation for both. Further surgical procedures that my urological colleagues very like to do are the resections of the bladder neck and prostate, because they think there must be any obstruction and I have to make the way free. But if there is a poorly functional external sphincter, then this patient can convert to a patient suffering from urinary retention, not so bad. He can still empty poor, but he is now also incontinent. The gynecologists, they want to implant urethral slings, and there will often be the problem, if there is incontinence, that if there is an underactive detrusor, they produce urinary retention. Now I can come to my conclusions and the take-home message. First, think of the autonomic nerve system and its devastating consequences for the patients. Bladder and sphincter dysfunction secondary to injury of the chorda equina or peripheral neuropathies are complex and often not predictable. They can result in severe neurological impairment, including the loss of voluntary voiding and urinary incontinence. No, I forgot something. It's very important. Think of bowel and think of sexual function. Think of bowel also when you give the pain medication. The detailed knowledge of neuroanatomy, physiology of the bladder and urethra, and special new nerve-sparing surgical procedures will help to avoid injuries, especially of the peripheral nerves of the pelvis. Surgical treatment of bladder dysfunction should be deferred until such a time that reasonable chance of functional recovery is unlikely. These are mostly 6 to 12 months. And the therapy should be as conservatively as possible and depends on the urodynamic findings. Conservative management, particular intermittent catheterization, should be the initial intervention. And last but not least, also think of pelvic organ dysfunction if there is a pain in this region. So I thank you for your attention, and I'm open for any questions.
Thank you very much, Dr. Angermuth, for this very interesting perspective in neurology. One remark from my side, we have 15 minutes over time. So I think if people want to stay for a discussion, please do so. I think everybody will agree to that. If you need your lunch break, I think nobody's going to be insulted if people choose to take the lunch break. So let's start with the questions. Ms. Brandt, please.
Yes, I would thank you for your interesting talk. I would like to take this opportunity to just ask you about this patient I saw. She came to me. I'm a pelvic physical therapist in Holland. She came to me with an overactive bladder, and she was saying, telling me that when she didn't have a bowel movement a day, her bladder would be more quiet and calm, and her micturition frequency more normal. And I've been wondering, since I spoke to her, is there any neurological explanation for this phenomenon, and which one is that?
Yes. First, it's all the same nerves, and we always say there's a bladder-bowel conversation, and we also see in the children. I have a lot of children. If the bowel management is good, the bladder function will be also much more better. And so I emphasize always that they have to look at the bowel, and this is a conversation. We know this. It is common knowledge. Yes.
Yes, and with like this lady had a big myoma on her uterus or in her uterus. Would that play any role in this?
I think this is always an argument of the gynecologist that this may be the reason for an overactive bladder, but I don't think that the influence on this is not so much the local the space that the myome will take in the pelvic is a large, huge sometimes, and you can imagine that there will be some influences. But I always think that there are other aspects like the hormonal situation, estriol deficiency, estrogen deficiency, and also the inflection of the nerves in this region.
Okay, thank you.
Okay, are there any other questions to Dr. Angermuth?
Thanks to her for this very complicated system explanation. I would like to... No, it's not. It's you, who talked very well, and I will listen to it in the YouTube repetitions, and I will next time I will ask you many questions. I hope this is a little bit different than what we do in the general daily practice. So I'm a musculoskeletal physician, so so we need more detailed information from you in the coming symposiums. Thank you very much. I just wanted to thank you.
Thank you too. It's different. It's difficult to make it more simple. The more you read, you're confused much more, and it's difficult to explain it more simple, I think.
For idiopathic coccydynia, it's important to know the autonomic nervous system and the innervation very well. I think it's very important to be also to understand that if why the manual treatments are effective, are helpful in some patients. I think if we touch the right points without knowing, sometimes we are successful about the pain in patients which we cannot see a radiologic finding in dynamic X-rays or MRIs. The manual treatments are sometimes very successful, and this may be the explanation the nervous system distribution, in my opinion.
There are a lot of things we don't know, but I always treat the symptoms, the signs, what I see, and what the reason is not so important sometimes. If there are morphological lesions, there are no morphological lesions. So I will treat the patient that has a better quality of life and the preservation of his urinary tract system.
All right, so if there are no further questions, I would like to dismiss everybody for lunch break now.